Hello, this is my presentation for my final paper for class social work 780. Um, just a little rundown of my paper. The population I decided to do my paper on is um excuse me, sorry. Population I decided to do my paper on is the military population. Um, from the trauma aspect, as many of our service members come back with either PTSD or depression when they are deployed. Sometimes military trauma is not even due to deployment, but on my final paper, I did focus heavily on deployment. But just to kind of give a rundown on what else may be a contributing factor to trauma within the military, it could be sexual abuse, misconduct, or on the job related incidents. So on the job training injuries, such as that. So military trauma. Clinical investigators have alleviated the symptoms that characterize war-related stress reactions and have devised models that explain the onset and course of these symptoms. In addition, they have developed increasingly sophisticated assessment instruments and clinical interventions to evaluate and treat combat veterans. So, a lot of the times when combat veterans come back from a deployment, even if they were not first-handedly in the line of war, some do come back with some sort of trauma. It could be being away from home for a long period of time. The living environment that they were in. As we all know, a lot of these men and women are not in nice houses when they're deployed. Living situations can be rough, depending on where they're being deployed, how long they're being deployed, and also what their job within the military consists of. So these are just certain aspects that relate to military trauma, and I do think it's a good thing that clinical investigators are coming up with different interventions to evaluate and treat these veterans, because some of this stuff does go unnoticed, unfortunately. So in my paper, I talk about my client dealing with SUDs and PTSD, and also depression as well. Just to kind of go over the rundown of the DSM-5's criteria for substance use disorders. One or more abuse criteria within a 12-month period, and no dependent diagnosis applicable to all substance except nicotine for the DSM-5 abuse criteria were not given. So just a few, 3 or more. So when you look in the DSM, there are going to be several criteria listed, and throughout my paper, I do speak about how the person that I'm working with, my client, does meet the criteria for PTSD. Some of it consists of triggers. Some of it consists of It could be behavioral, avoidance, and then self-medicating as well. So with my client having an SUD, he is self-medicating for his PTSD. And that's one thing that I touched on strongly throughout the paper. So PTSD, and I know PTSD is followed up with the military a lot, but there are other situations on why a person may be diagnosed with PTSD. And it can consist of exposure to death, threatened death, actual or threatened serious injuries, actual or threatened sexual violence, and the following: direct exposure, witnessing the trauma, learning that a relative or a close friend was exposed to a trauma, indirect exposure. And these are, and some of the people that unfortunately are diagnosed with PTSD are first responders, medics, and military personnel. This is information that was provided from the VA. So within my paper, I speak about how my client, he was exposed to death, and then he was actually shot while in the military, on a deployment. So he's a mixture of both exposure and direct exposure, and also experiencing trauma. And that is one of the reasons why he is self-medicating. He has a hard time adjusting to the civilian world, as they would say, due to some of these exposures. And throughout the paper, I speak about how his PTSD, his depression, and his SUDs are not being treated for, and that's part of the problem why he's having a hard time transitioning into the civilian world. Understanding triggers for PTSD is a big one. Most individuals struggling with PTSD have triggers that they may or may not be aware of. It is important for the individual to be aware of their triggers to avoid incidents from occurring. Self-medicating with drugs or alcohol is not something uncommon for those to do that have been diagnosed with PTSD. When self-medicating, this could cause a trigger without an individual realizing it. Triggers can consist of something small, such as a room having no lights, to something big, such as fireworks. So I strongly believe when someone is diagnosed with PTSD, understanding their triggers is very important. Because once someone knows what their triggers are, they have, if their PTSD is being treated, they have a better chance of avoiding those triggers. Not saying that a person that is not treating their PTSD cannot avoid their triggers, but when you're getting help and realizing, hey, this is what bothers me, it's more eye-opening to an individual rather than a mental health problem being untreated, and then they're guessing on their own that, hey, maybe this is what bothers me, or maybe this is what doesn't bother me. So understanding triggers of PTSD is a really big one, and it is also something that I spoke about in my paper as well. At least making sure my client is aware of what their triggers may consist of. So to summarize my final paper, so my client, he decided to join the military to honor his father that died while serving in the military. It is spoken upon about his father being in the military and having an alcohol problem, and his paternal grandfather having an alcohol problem too. So that is touched upon. So as I spoke about a little earlier, my client is battling with PTSD, 2 SUDs, and depression. The client is so as I previously mentioned, he was exposed to seeing a friend die and being shot in the military. The client is having a hard time transitioning into the civilian world. Actually, once he was done serving, or once he got out of the military, things kind of start the down spiral for him. He has had several thoughts of committing suicide. He got into a relationship that did not end up working out, but in the midst of that relationship going south, his girlfriend did become pregnant, so he does have a young daughter. He's having a hard time with job stability. He's having a hard time with coping mechanisms, and he's just having a hard time grasping his life. One big thing about this client is that he enjoyed serving in the military, and getting out was something that was unexpected. But since he's now out, his transition has not gone smoothly, and he's living with his brother, and he's fighting off some addictions, and he's just trying to learn how to piece everything together, to get better. And that's one of the goals throughout my paper, is to help my client live a more meaningful lifestyle. So throughout my paper, I truly wanted to touch on some of the key components of military trauma and SUDs. It's something that's very common within the military population, which is the military and the veteran population, which is experiencing trauma and self-medicating due to the trauma. I do believe, to some people, they're like, well, this is what they signed up for, so this should be expected, and that's not the right attitude to have. No one is signing up to have PTSD or to be depressed or to have an SUD. They're signing up for different reasons, such as serving their country, honor, respect, or maybe it's even a family tradition that multiple people within their families have joined the military, so they want to keep that going. So it's not something that's talked about a lot, and as of late, and what I mean is, as of late, I would say within the past 10 to 15 years, it has gotten better with recognizing PTSD, how to treat it, how to treat SUDs, and that's fantastic. But as a society, we still have a long way to go. So thank you, Dr. Sun, for listening to this presentation, and I hope you enjoy everything that's in my paper.